Anybody? Okay, good afternoon. Good afternoon. Allow me to take this time to welcome all of you as we go through this session. And the session that is before us is on clinical science, treatment, care, B3 co-infections of TB, hepatitis, and STIs, Cryptococcus, bacterial diseases, leishmaniasis, malaria, and the others. And with us here, we have the presenters. This will be an abstract-driven session, and therefore we are going to be taken through abstracts. I take this opportunity to welcome the presenters. Welcome. And therefore, we are going to go through, we'll have 10 minutes for each of the presentation. And allow me at this point, because of time, my name is Joshua Gitonga from Kenya. Allow me to start with the first presenter who is with us, and that is Davis. Davis is from Lighthouse Trust, Malawi, and Davis is a clinician. Let's welcome Davis. Davis, welcome.
Okay, thank you so much. I'm Davis Kabenga from Malawi, and on behalf of my co-authors, we'll present on the high yield of cryptococemia and cryptococcal meningitis for inpatient at Kamu Center Hospital. Next slide. So we know the burden of cryptococcal meningitis in globally, estimation of 152,000 cases, and out of that, 82,000 are in sub-Saharan Africa. We have had those type of presentation before, and on the death, we also know that 122,000 deaths in globally in sub-Saharan Africa, and 63% occurs in our in our region. And Malawi is one of the countries we are having this burden of death due to cryptococcal meningitis as one of the HDAs. Next slide. Just basic observation as a clinician managing advanced HIV in our setting. Most of the patients we see coming in because of HIV positive in the ward who are admitted in our wards. And those who are HIV positive, they are admitted because of frequent rare advanced HIV disease. We have seen that in our previous presentation. In our setting, like 48% of the patients admitted at Kamusenda Hospital, one of the referral hospitals in Malawi. We have 4 referral hospitals, and Lighthouse Trust is working in those inpatient. We see more patients admitted with low CD4 count with advanced HIV disease than the national data. And our program is funded by Global Fund and PEPFAR. We see this program as a vertical type of approach, where you see on the picture that better funded ART sites, but few advanced HIV patients. But if you look into the patient, into the ward, you see it's underfunded, overcrowded medical wards with more advanced HIV disease. We as Lighthouse, we are looking at inpatient care in terms of managing advanced HIV disease. Next slide. So as I've already said, what we have done as Lighthouse, as in all facilities, we have identified a room inside the medical ward where we have HDAs, diagnostic HIV assistant. They go around, if they find any patient who has been admitted, new or a patient experienced or a patient naive, we do a CD4 count for all those patients as a point of care. So in that room, we have a nurse, retention assistants, and a clinician. So if a patient is tested, it is HIV positive, we are doing right away point of care CD4 count. And if the CD4 count less than 200, as you have already known, we do urine alarm and serum crack. And inside that room, we also have all the drugs available for TB, for meningitis, and for ART itself. Next slide. So for management of cryptomeningitis in Malawi, we are using Ambition trial, and we are based on 2022 clinical guidelines, where we are giving ribosomal for terracin B as a single dose, plus 14 days of fluconazole and fluoxetine. Additionally, we also use pressure management as recommended, but due to limited resources, you see the picture there, we are using an IV giving set because we don't have the manometers. They are very available for measuring the pressure. Next slide. So in our inpatient advanced care, we had an overview of 2 years overview of data. And from July 21 to June 23, 9,395 admissions were recorded in our ward. This is at Kamusenda Hospital, the main referral center. And we ascertained 6,182 were HIV ascertained, representing 65.8%. And out of that, 36.9 were HIV positive, roughly around 2,000 patients in that period. And in the same period of 2 years, 244 patients were newly initiated on ART, and out of that, 34.3% were classified as stage 2, stage 3, and stage 4. 502 patients were started on TB treatment, and roughly around 375 had HIV co-infection. So, as I've already said, 36.9% were HIV positive. We did point of care CD4 count for all, and out of that, 42.2% had a CD4 less than 200. Next slide. So, of the 988 were at CD4 less than 200, and we have a coverage of serum crack of 88.8, and we yielded 83 serum crack were positive, representing 9.4%. For those which we yielded serum crack, they have a medium age of 39, gender, male and female not much different. They have a medium of CD4 count of 65. There were 2 patients with serum crack positive, but the CD4 count was above 200, roughly 2027 and 344 respectively. Next slide. So of the 83 patients, which we had serum crack positive, 69 had a lumbar puncture. I was done, and 43 patients had serum crack positive. The 14 patients, we had no lumbar puncture. Common reasons, some death before lumbar puncture. Some patients, because of myths, we are refusing to have lumbar puncture either from the guardian. Yeah, some lumbar punctures were repeatedly unsuccessful because the patient was very sick. So, but all the patients were treated according to Malawi National ART guidelines, and treatment outcome is not really recorded. Next slide. So, For the 6 months QI project, which we took from May 2022 to from November 2022 to May 2023, 401 HIV positive patients were followed up to discharge, and they had interesting findings. 28 had serum clot positive, 6 were CSF negative. We followed up the 6 up to discharge, and cascading the 22 patients were analyzed in detail, and we had a mortality of all patients were 36.4%. That is 8 patients died when we follow up in the first 6 months. When we had a 36.4% mortality of all patients, we analyzed the 8 patients which died, and 2 died before lumbar puncture. We look at the remaining 6 patients which were remaining, and we find that the mortality of patients who are serum clot positive, CSF positive, were actually 30%, like a mortality. And we analyzed the 6, we find 4 died before ambison was started, which was so interesting. We look at the remaining 2 patients and find that the mortality of those who have serum clot positive, CSF positive, and given ambison were 2 patients out of 16. So the mortality was reduced to 12.5%. What did we conclude? Sclerotic meningitis patients die quickly. From my experience as a clinician, they die quickly, and from this data, if the patient survive enough long and that LP lumbar puncture is done, ambison is started, you see the mortality is reduced to 12.5%. And that's my last slide. On conclusion, hospitalized cryptococcus meningitis patients die often, rapidly, and diagnosis and treatment are urgent and need to be available on spot. Screening for HIV patients yield a high proportion of advanced HIV patients, and we also concluded that a serum reflex clot testing and the lumbar puncture with a CSF clot identifies a high proportion of patients with cryptococcus infection, allowing a stage-adjust treatment. One thing we have observed from this QI was ART programs can successfully support inpatient care in collaboration with the medical wards in the ward. I think that's my last slide. Thank you.
Thank you so much, Davis. My suggestion is that we go through all the presentations. Once we finish the presentations, please keep the questions so that we can be able to ask to the presenters. Thank you so much, and quite critical information that is coming, even as we think of the advanced HIV diseases and even issues to do with crypto. I think we need to address, and the drug administration. So with that, allow me then at this point, and I also want to mention that I'm standing in for Dr. Ruth Masha, who was supposed to be moderating, but I'm standing in for that moderator. If there was any other moderator for this session, you can join me here. Okay, thank you. We go to the second presentation. The second presentation will be made by SAADICK. SAADICK is doing a master's in science of public health at Suffolk University, UK, with a postgraduate diploma in project planning and management, and a doctor by profession with the Bachelor of Medicine and Bachelor of Surgery, and works with the AIDS Information Center as also a quality improvement and knowledge management advisor. Join me to welcome SAADICK to make the presentation. SAADICK.
Okay, thank you. Thank you very much, team. My name is Dr. Ssentongo SAADICK from Uganda, and I'll be making a presentation on community-based TB screening using artificial intelligence software-aided chest X-ray in TB in Katakwi, Northeastern Uganda. As we are all aware, recently WHO issued the report which showed around 1.3 million people who died of TB, with over 10.6 million people that fell ill with TB, and for MDR having 2 in 5 being able to access treatment. And of course, knowing that TB is still the second leading cause of death in infectious diseases, second to COVID, that makes TB still a very serious disease across the world for us to monitor. Next slide. So this presentation comes from Uganda. I try to, when you travel abroad, it's better you introduce your home. Katakwi district is one of the 10 districts in Teso sub-region in northeastern Uganda with an area of around 13,000 kilometers. The region has an HIV prevalence of 4.2% and an a viral suppression of 77.2%. Of course, this one points to the TB you might get, given the fact that majority of the clients with TB are people with TB. And this project, initially the work was done under TASO, Soroti Regional Project, though now it was transitioned to AIDS Information Center Soroti Regional Project. And it's a CDC project supported by PEPFAR, supporting across 111 sites. So next slide. Basically, what prompted the initiation of this work, we realized that in 2019, across Uganda, 75% of the estimated TB cases were diagnosed, meaning that 25% of the estimated TB cases in the country were missed. That was approximately 4,800. These are not just numbers. These are people who risk death and have families. And not only that, that was at the Ugandan level, but when we moved across Teso region, it was also clear that 44.9% of the estimated number of TB cases were missed, and that was approximately 1,569. When we did a deep dive through the RCAs, we realized that the main reason was the low TB symptom reporting and the inadequate implementation of the traditional symptom screening tools. For those of us who have been following TB programming, we are all aware in 2016, WHO looked through and they discussed the use of computer-aided chest X-ray, but that was not finalized until in 2020, when the WHO Global Guideline Committee sat again and put the computer-aided chest X-ray in the guidelines to complement the screening tools that have been available, following the different studies that showed this, the superior of having computer-aided chest X-ray reading as compared to only human being testing. Of course, this initially was implemented at a facility, and this prompted us to take it to the community due to the improvement in modalities to see how best we can have this cascaded. So in this study, we are trying to show the use of community-based TB screening using the artificial intelligence software in Katakwi in Northeastern Uganda to aid with improving case notification. Next slide. Of course, for the problem statement, I already talked about it. For the different publications, I quoted some of the publications. It was noted that some of the clients do not present with the the typical clinical signs, the cough, the fever, the loss of weight. Some clients presented asymptomatically, in that if you do not use these improved version of screening tools, you might end up missing the clients. So that's the reason why we prompted using the chest X-ray, given the different science that showed that significantly improves the existing screening tools. Next slide, which is the chest X-ray, the WHO for symptom tools, and the other customized symptom tools. So justification, we have talked about it already in my preamble, as the need to have this chest X-ray to support with the visual interpretation of the chest X-rays, given the different studies that showed the inefficiency of using only human beings or health workers to interpret a chest X-ray, prompting us to supplement it with the computer-aided chest X-ray, but more in the community. Next slide. The objectives, we can go to the next slide for the case of time. I'll say it. So I've talked about the things. So when we went to the village, of course, our aim was to assess the computer screen, but also add other specific objectives, which was to conduct targeted TB screenings using chest X-ray and TB hotspots and among the high-risk communities, as we shall see, and also to support in raising awareness within the community about the TB by facilitating the increased participation in TB screening by the community members. The other three objectives was to ensure that we perform comprehensive laboratory and clinical investigations among the presumed clients to ensure that we start them on TB. So the methodology, that is after WHO had integrated it in the guidelines of 2020. Of course, our Global Fund and PEPFAR picked it up, and in our region, we are able to have it. And in June, with TASO, we are able to engage our health workers, where we trained one clinical officer, one nurse, and one data clerk who are supposed to support with the capturing of the data in the community. And these we are trained on how to use the computer-aided X-ray. On the side, you can see that picture where one of the health worker was engaging the clients in the community on TB screening and also the signs and symptoms. On top of that, after training them, this trained health worker used the TB register and they identified the outreaches, the hotspots where TB was more prominent. From those hotspots, we are mapped out and we engaged. Our second objective, we talked about increasing community participation. So we engaged the community health teams to support the mobilization of the people or the clients in that around the hotspots on a day before the outreach. As you can see in the second bullet, that is we supported by the community resource persons, conducted the door-to-door mobilization a week prior to the train for the outreach. Next slide. So after that, we adapted the WHO symptom screening. I started with a brief on the utilization of this mechanism, the four ways we can use it. So of course, we use the WHO symptom screening. We screen those clients, those who are symptomatic, were exposed to the computer-aided chest X-ray, and those with the score of greater than 50. This was a calibration done by the Ministry of Health, where it gave samples and was sent for gene expert. You can see the picture on the right from one of the sites in Soroti district, clients waiting to go for the screening within the room because it was community. Next slide. So from the results, you can see how impressive it was. From June 2020 to September 2022, we are able to reach out to 1,064 individuals who were screened using the AI chest X-ray. Of these, 3,000, that was at the facility. 3,328 was in the community. This shows you that there was maximum cooperation in the community, because you can see the number in the community is slightly higher. What does this mean? It means that if you bring the service closer to the communities, they can willingly participate. And you can see of those that were screened, 11%, that is 482, had a score of above 50. And all of those gave us samples and were taken for gene expert. 32% of those who had the higher score had TB. So that is the 154 to 482. Of those, we try to compute the total number of cases we got in that district. We realized that 25% of the TB cases, the 154 over 611 were through this intervention. What does that mean? If you had not done that intervention, we would have missed these clients. And also, we are able to see that the 75 were through other traditional screening tools, which are very many. So this shows you that if computer-aided chest X-ray can contribute 25% of the TB cases, that's a significant number, which we really appreciate. Next slide. So I've already summarized this. We also noted the increment in the TB case identification from 70% to 110, again, is the qualitative target, because every quarter we expected to have 95, but with the introduction of this intervention, we saw that the case notification improved to 110, which was significant for our programming. I might not go into the graphs because of time, but you can clearly see on the left in the comparison between the individuals that we are screened across, you can see a big number of TB cases being in the community with over 88%. So 88 TB cases vis-a-vis the 68 TB cases at the facility. What does that mean? It means that trying to innovate and we push these X-rays not only at the facility but also in the community hotspots, it will support us get more TB cases. Next slide. Next slide. Yes. So in conclusion, what we found are the lessons we learned that using community-based AIHS excellence significantly improved the TB case finding, as you saw, from 70 to 110%. Engaging the community resource persons in the mobilization created ownership. You saw over 3,000 clients are turning up for the screening. And also we realized that combining the AIHS excellence supported with complementing the other screening tools to reduce on the different cases missed. So one of the recommendations to which we made to the Minister of Health was to support with the scale up of this approach, because in 2020, of course, it was one district in the 10 districts. We seconded, and of course, with this data, we started the mobile chest X-ray, the mobile vans, to ensure that we are able to get this. And also one of the things we are thinking of doing to assess the impact of community engagement on the success of the TB screening and initiatives, and also trying to explore the feasibility of having the AIHS excellence not only in public facilities, but also in these other private facilities to ensure that we are able to get this, and also are requested to have more point of care testing for TB given the burden. I conclude by thanking PEPFAR, which supported this work, CDC, Ministry of Health, TASO, where the work was done, AIDS Information Center, and our project director, Dr. Baker, who is also with us here for ensuring that we have this work done. Thank you very much.
Thank you so much, SAADICK. I think really bringing in innovation for us to improve the identification, and clearly coming out that when we kind of enhance the models that we have and take the screening near the population and the community, then chances are we are able to have fewer misses and be able to identify more. I think that's a great thing. Thank you so much, SAADICK. I know that the audience and the participants will have questions later. At this point, allow me then to go to our third presenter. Ardate, to take us through the third presentation. And she is a medical doctor working in a clinic as a medical officer. She has experience in working in different backgrounds and around Africa, Algeria, and she is pursuing. Okay, so she is a medical doctor, and she's going to take us through. But right now, she's looking at issues to do with policy in Africa, and therefore help me to welcome our third presenter. Welcome.
Good afternoon, everyone. I'm Dr. Tepiwanashe Adelaide Chawafambira from Newlands Clinic, a Swiss-funded organization that takes care of about 8,000 people living with HIV. Today, I'll be taking you through anogenital warts in young people who are enrolled in care at Newlands Clinic. Before I go into the presentation, I'd like to acknowledge Dr. Margaret Pascoe, Dr. Sarah Lowe, Dr. Tarisai Kufa, the Newlands team, the recipients of care who have managed to put this presentation in place. I would also like to thank the country, the organization, the organizers of ICASA, hoping that our presentations would have a target and would affect policy changes. To take you through my presentation, this is the outline of my presentation. And to start off with the introduction, slide please. We know that anogenital warts is a common disease that is caused by HPV, and we know that there are more than 200 subtypes of HPV. And we also know that 90% of these are caused by non-oncogenic subtype 6 and 11. We also know that anogenital warts are responsible and cause a significant morbidity and mental health challenges. There's a social stigma that is associated with young girls that present with anogenital warts. And these patients suffer from low self-confidence, they have depression, they have sexual anxiety, they also experience decreased libido, and also their quality of life is significantly reduced by these anogenital warts. We also know that these genital warts, for these patients, they present a burden in terms of treatment expense and the chronic nature of the disease. Next slide, please. For the risk factors of anogenital warts, it's been noted that multiple sexual partners are a contributor to someone acquiring anogenital warts because of the multiple inoculation with the HPV virus. We also know that vertical transmission is a risk factor for someone having HPV. A child who's born to a mom who has HPV or genital warts has a higher risk of acquiring the virus in the perinatal period. We also know that someone who's got a compromised immunity has a higher risk of acquiring anogenital warts. Slide, please. For the treatment modalities that we use in Zimbabwe, we take into account the number of wards, the size, and the location. And the treatment modalities include pharmacotherapy, podophyllyn, which in our local guidelines is the first line of treatment. But we have also known that imiquimod, which is an immunomodulator, has proven to show better outcomes, though the cost is superior to podophyllyn. Some patients will need to have cryotherapy, where they use liquid nitrogen to freeze these warts, and these patients will need to have multiple series of intervention for them to reach some level of cure. And then there are other methods that we use, laser and excision and cauterization for the larger warts. And these usually are, these services of laser and excision and cauterization are in selected health centers. Next slide, please. For our methodology, the study setting, as I mentioned before, took place at Newlands Clinic, which is here in Harare, Zimbabwe. We take care of 7,800 people living with HIV. We offer a comprehensive outpatient care for their HIV. We did a cross-sectional analysis, retrospective review of their patients' notes that are kept in an electronic data. We extracted 169 files of young people aged between 15 and 24 years with a diagnosis of anogenital warts made between the year 2012 and 2023. The data we collected included demographics, the HIV disease parameters like viral load and their CD4 cell counts. We also took into account treatment modalities, the outcomes of those treatment, and the vaccination status. Slide, please. I will take you through the results. And as I mentioned before, we extracted 169 files. 77% of them were female. 65%, 77 of them were females. And the median age was about 20 years. 65% of these patients had a viral load of less than 50, and 23% had a viral load of more than 1,000. We also noted that 23% had advanced HIV disease with a CD4 cell count of less than 200. Of these patients, 8 had a documented vaccination status with the Gardasil vaccine, which we are offering at Newlands Clinic. I'll go into detail on the vaccination status. To go on again on our results, slide please. This is what I just mentioned earlier about our age distribution and age and gender distribution. Next slide, please. As you can see on the slides, and as I mentioned earlier on our treatment modalities, we've got pharmacotherapy, where we offer imiquimod or podophyllyn, and 25 of our patients received some sort of pharmacotherapy, with about 60% of these patients receiving imiquimod. The other patients who received surgical treatment, you can see that on the chart, those who received cryotherapy were about 60%, 103 out of the 169 had cryotherapy. The rest had a mixture of either cryotherapy with laser, either excision and cauterization with laser, or some did not receive any surgical treatment, especially for those who presented with a diagnosis of anogenital warts, but also were noted to have a high viral load. These tend not to need treatment once they manage to reach the immunity control. Slide, please. So to sort of look at our outcomes by treatment modalities, as you can see, not one treatment for us to achieve cure. And in terms of cure with HPV disease, we know that there's a tendency of recurrence. Our definition of cure meant that we have cleared the current disease and the patient won't be needing care at that moment, but also taking into account that there's a likelihood that this HPV virus would recur. So for someone to achieve what we called cure, they needed more than one treatment. For someone who, for example, received imiquimod, we realized they also needed to have cryotherapy for us to say they've reached cure. And for those who had excision and cauterization, also needed some sort of pharmacotherapy for us to say we reached cure. We also take note that the patients, there's a large number of patients that did not need any surgical treatment. And usually these are the patients who at the diagnosis of HIV present with anogenital warts, but once their viral load becomes undetectable, we usually just see we don't need to there's no need for us to intervene in that case. Next slide, please. Coming back to the vaccination status, our national program offers the Cervarix vaccine, which protects the young women against the subtypes 16 and 18, and this is only restricted to young girls between the age of 10 and 12. Us at Newlands Clinic, taking into account that most of the anogenital warts are caused by the subtypes 6 and 11, we are offering our patients the Gardasil vaccine, which protects against subtypes 6, 11, 16, and 18. And we've been offering this from the year 2014. And unfortunately, over the COVID period, we ran out of stocks of our Gardasil. So at the moment, we are only offering our young girls between the age of 10 and 17. So the status of our 8 patients who were vaccinated, we noticed from their treatment outcomes, 5 out of 8 were cured, 2 were lost to follow-up, and 1 was undergoing treatment. And those that managed to get some sort of cure, they received, 75% of them needed cryotherapy. Slide, please. So from our conclusion, we noticed that having anogenital warts is very common, more common in young women living with HIV as compared to the male counterparts. And we also noted that antiretroviral therapy and optimal HIV disease does not necessarily protect someone from acquiring or developing anogenital warts, which brings back to my recommendation, which I am strongly recommending and hoping this can be taken into account. It would be good, slide please, it would be good that there is reconsideration on using the Cervarix vaccine, on using the Gardasil vaccine as opposed to the Cervarix, which only offers protection to types 16 and 18. So we are highly recommending quadrivalent HPV vaccine to prevent the development of anogenital warts in these young people. I thank you.
Thank you so much for that captivating presentation. We truly appreciate. And I think as we are moving forward, we know that the discussion around HIV will not happen in I mean, it will not be a separate discussion from the other conditions and diseases that surround the issue of those living with HIV. And I believe our three presenters have given us three scenarios that we have to work around that face us when we are trying to manage and ensure that the quality of life of those people who are living with HIV is improved. And therefore, I will, at this point, open up for questions.